provide support. We had the opportunity as well to organize a amylosis day that was held last year on the 26th of this year and on 26th of October, which is it's a rare disease that is not known to most French Guyanese people in So I'd like to thank everyone who's worked on this and to do this, and I'd like to thank all the professionals who worked on this. With Comarg, we had we organized a one day with Teleton. We plan on setting up some training with rare diseases for health professionals, organize UPU for GPs, specifically on rare diseases. A clinical research staff who is going to be hired as well in order to feed the database, and the 2023 Rare Diseases Day, which is going to be held on the each year on the 28th of February, as we just said, last day of February each year. So this day is going to be held at the Hospital Center of Western French Guiana. Good morning, everyone. I'm Mrs. Wiltor, and I'm a social worker at the platform coordination platform for rare diseases in Martinique, AMR. We're going to present some of the actions we've conducted since the start of this platform. At the start, we devised and designed tools as it was necessary, forms, identification forms that patients, people were filling in. We worked with Mrs. Louison here today from representing French Antilles Guyana. So every other month we have meetings. We meet, and we met also with our partners, GPs, Rare Diseases Alliance, Andy consult of the hospital with Professor Barnes. He's heading this. Martinique's Association on Myopathies. And we also are in touch with another organization based in French Guiana that addresses these problems as well, and working on the Rare Diseases National Data Bank. We also took part in co-steering committee meetings on coordination of actions, and we took part in various work groups in the Neurogenetic conference in 2022. We organize partnership meetings we often come across. We have patients or associations, families with complex handicap situation, disability, and so we need to hear what they have to say, find relevant solutions, or find appropriate solutions, and if we cannot provide this service, then ensure that we're going to give them the proper tools or give them information to know what to do. Also install new centers, have training students from the University of the Antilles and French Guiana. Good morning. Regarding training for young staff, we have provided support to a young patient with affected with rare disease, and his work was too demanding, and so we provided him support. Doctors asked us to help him and to find a better suited work, and so in this respect, we are helping young people. And we also have drafted rare surveys with doctors, with liberal doctors or freelance doctors or non-state doctors, and that pointed out at that these most GPs, doctors, general practitioners did not know about this rare disease platform. So we need to make sure that everyone knows we do exist. And also activities, supporting activities, the health hospital. I mean the hospital as well. We supported cardio specific activities. We also provided support in diagnosis to patients. And with regards to some of the patients with no diagnosis, we help them in terms of making appointments for them from the start. They turn to us either by email or they call us, or sometimes they even come to us directly. So we receive them and we listen to them, and this is not just a starting point and then we just let them go. No, we're providing support from point A to B. You know, when you've got no diagnosis, we don't want to let them wander around, and we try and get them a meeting or an appointment, not a meeting, an appointment. Also training, professional, vocational training for patients with rare diseases. So this is our project, and find trainings. These patients at home with no work, children who do not go to school. Some parents would like to know what's being done for these children. So we are looking into what is in place already for these people and how can we provide support. What is really available. How funds are also used. So we are trying to do this from our platform, organizing as well the ERCP, Hello Rare Diseases. It's a pilot platform network as well for the Health Hospital of Martinique. For months now, we are an ERCP with Eurofim. And there was also a video consultation meeting. I was trained to do this video consultation and participation in participation in the JCMO, so Rare Diseases Caribbean Days 2022. So we are trying to be involved in, being involved in all actions being held at the Caribbean level. When the patients call us, patients call us and they say, well, they've heard about us, but most of them didn't know really that we were in place. Since 2021 till today, 107 people got in touch with us. We have patients from neighboring islands via this platform. We forgot to mention that we have a Facebook page. We've got an Instagram page as well. We're on Instagram. And we have Twitter as well, yes. No, I think you listed everything, and I think we're going to give the opportunity to ask questions, for the audience to ask questions, if you have any questions. Good morning from Nantes. I'm very pleased. I'm very pleased to hear what you just said, and all the activities you listed. That's exactly what we are doing in Nantes, which is a local platform called Prior. This tender really goes back 2 years ago, and in Nantes, that was led by a genetics expert. He was the one who actually started it. So since 2010, 2011, we started on it. So all the missions that you listed is specifically, the patient's pathway, health pathway is really crucial, really important to provide them support. The support, on Bamara. The point is for them to catch up on the capacity centers, capacity building. Prior, that's what we did with Prior and referral centers. We are really pleased to see that you are really being proactive. These platforms are not on the forefront, but still the patients are making really the most of it and really need these platforms. And we sometimes, we want to say, well, platform for rare diseases. Well, it's difficult, to really see the point of it. But in the long term, I think these platforms are really, really important. So well done and carry on your work. Thank you. Thank you, Jan, for saying this. Yes, good morning. Last lady, I heard you say that you had a young person, a young person who found it difficult with his work, and there is a mechanism that there is a program for disabled workers, and there is an organization in Martinique based, that can that is handling this kind of situation. They provide the staff as much as the employer. It's called ARFAC, yes. Yes, ARFA. I'm working for the ARFA, which is providing support to disabled workers. Mrs. Louison, working rare disabilities. It's the ARFA Association which coordinates the mechanism program to provide support. Taking this opportunity to back up what Jan has just said. Jan talked about the Prior, which is already 10 years old, and as you think is across all the axes, all the actions that you've described. You cannot, with your funds, the funds you've been allocated, and you cannot meet all the requirements of these axes, all 10 axes. So you need to prioritize what to do rare disabilities. This association is already up and running, so they can already, they can provide support as well. They know, they've got background on this. You need to link up patients, practitioners, and rare disabilities. So carry on with communication and targeting the communities as much as health professionals, as Jan has pointed out. Still, 10 years down the line, still loads of medical staff not knowing about this platform. So don't get lost in, trying to meet the requirements of all these axes, all 10 axes. Just, focus on 2 axes. And the first one is communication to the patient. Yes. Good morning. I wish to thank this initiative, or welcome this initiative, a work that work of a year's work, and I believe what has been completed is really very important. Our rare diseases taught at the university, with nurses in nurses school as well. Dr. Gillard allows me, I'd like to add on to what you just said. We had 2 webinars on professional inclusion. APF for Guadeloupe's hub. So we represent AFM Teleton in Guadeloupe. We know how crucial it is to include professionals with regards to health professionals, rare diseases, rare professionals.
Bonjour, Stéphanie Luzieux. Je suis
Stéphanie Luzieux, and I'm a mother of a child with a handicap. AFA is up to 20 years old, and then there's no more support after 20. You talked about AFA up to 20, so when you are 20, then afterwards there's no more support provided. ARFA has 9 units in the ARFA. IAC is one of the mechanism at the ARFA. So it depends what you need, really. ARFA has different services. There's no limitation in terms of the age of the patient, of the person. I am the mother with a handicapped, disabled child, and it's difficult, really. My name is Mrs. Félicité, and I'd like to say how pleased I am to see the work completed by these platforms and their coordination. Cyril, please tell us a bit about teaching or what is taught at the university level, talking about rare diseases. Yes, this question on rare disease teaching. Yes, no, there's no specific teaching. Presentations, yesterday's presentations, and really show how diverse and heterogeneous these diseases are, with mechanisms that vary. We cannot have teaching modules that would cover all the rare diseases, but yes, sector per sector. So FINEMUS, yes, they have specific teaching modules, and have combine all rare diseases, that there is some cross-matching, and we need to coordination solutions, and we can just, just apply these coordination actions quite easily, and these expertise platforms could provide support in this way, in this sense, and via their communication missions and some knowledge to be imparted to everyone. We cannot consider or think that we are going to have national teaching programs with this medical, social, therapeutics, and so on and so on. So yes, of course, there are joint elements. I mean, not joint, but similar points that we find. But if we could still, I totally agree. Disability, just disability, teach about disability. Regarding from a research point of view and developing innovative new therapy solutions, these are rare diseases or models really, and working models. So we could shed some, use that and shed some light on the whole situation. I'd like to tell this panel with regards to rare diseases that contributed to the drafting of this program. We are planning on having a meeting with Philippe Berta. He's a deputy and is really really interested in research, and another lady as well. So I'm turning to you and asking you what's impact, what is impact? Is there anything that could be fed back at the political level, government level? What do you wish to do, or what's your wish? What is it that you'd like? I can just imagine what you're going to tell me, I guess, means, of course, yes, means and resources to carry out our missions and actions. And in self-sustainability as well, so sustainability of... so if we have these two tools, resources, means and resources, as few of us, it's very few of us, and have this to be ensured that we are going to be sustainable. It's 3 years to be officially identified as a platform. Yes, many centers have actually noticed that. So national centers, genomic center. Did you notice, here's some connection with a national program and your program as well, or... I think, yes, we really need medical genetics services. We need to really strengthen the medical genetics center, genomic staff with RCPs, I believe, that are in the pipeline, and strengthen medical genetics. Remy, Mr. Belance, Dr. Belance. Yes, still lots to be done. A lot to be done in our area, because our teams are understaffed, under-resourced, and under-sourced, and underfunded as well, and we can conduct punctual actions. And the prescription cell, we were not able to have access to this cell being created. So at this stage, even just at this stage, it's really difficult to move forward. So we need support, support with regional health agencies, hospital level. There is a lot to do. We have here some specific pathologies, and which we need to be working on. Very interesting themes which are getting a lot. Each time we meet with the ministry representatives, and he tells us about the representative, the rare diseases representative. So we like at the Health Regional Agency, but we do not have access to this person. We do not know who this person is, and it sounds like no. Well, we don't know who is, if there is one even. In French Guiana, it's three of us: Professor Elanga, Marika, and myself. So three of us are the center actors, main actors. We are already working full time at the hospital, and hence the difficult it is for us. Our funds are not enough. The coordination secretary is a half of the 100,000 euros we are allocated a year. So we need to have a budget which is in line with the actions we need to be conducting. What we wish to do, especially in French Guiana, where precariousness and basic life conditions are really there, really. So when you go to Saint Laurent on the Martinique, you need, the 2 days. You need to go on fishing boats to go to some places of French Guiana. There are no planes that can take off. We need social workers specifically working with this platform. We need a nurse as well. My MDPH, my ALD, which is a long-lasting disease, I need to stop. So I need to go and work with the social worker from the pediatrics unit, and I need to go and see with her, and I need to ask her to do this. And we have so many issues we need to cover, but build on capacity building and strengthen as well the staff, human resources. Martinique, Guadeloupe. We've been in place since October 2020, so fairly recently. So we need to build on gradually. So we're working Axis 5. We need to move forward, and we need to turn to the patient. We must be able to go to see the patients. If we do not have a full staff, we won't be able to make it. So I'd like to thank all the actors, and we're going to move on now to the next platform.
Bonjour, vous m'entendez? Can you hear me? So we will continue with the neurogenetic session. And because of the agenda, the second communication will come first. So we will welcome Professor Fanny Moschel, a genetician at the Salpêtrière Hospital, and Odile Busflu, neuropediatric pediatrician at Robert Debré. So you have the word in Paris. So good morning. I don't know if you can hear me. Yes, very good. So if you can hear me, that's perfect. So we will try to present what is our reference center. We are sorry not to be present here in the West Indies. We were informed quite late, and we didn't find anyone to help us to come. And we represent a very active sector. This is the brain team sector, and the reference center for eutrophies, including all the diseases, related diseases, is still a small structure, but we work a lot with neurogene, and we work with Milton for the rare inflammatory diseases, and the presence of Fanny Moschel was animated the neurometabolic diseases. And I wanted to do this introduction to tell you that we would be very happy if you could participate, be involved in our work. We have the island of the Reunion Island participating with us because they have a specific leucotrophy. And we have our reference center where we discuss if a disease is inflammatory, is metabolic. And so we have two possibilities, a possibility of child and adult. And we discussed the possibility to c'est ça, canvas. So, and we will see if the diagnosis of leucotrophy, if we use ça. So we have some Sequoia and Oragen reference for the different possibilities, and we have some therapeutic RCP because we have a lot of pathologies which have some therapeutic possibilities. So Fanny Moschel will talk about this leukodystrophies. And so we will talk about the adult leukodystrophies because we won't have time to talk about the others. So Fanny Moschel will talk, and she will be. We will have a center for leukodystrophy. So thank you very much. Good morning, and I'm very happy to be with you for these days. And as Odile was saying, of course, we would like to be in Martinique. We wish we would be in Martinique instead of behind our computers. So we use a new platform. Can you see my screen? Because I cannot see it any longer. Yes? Oops. We cannot see the presentation. We see the screen. Can you see the slides? Yes, it's almost good. Yes, that's okay. Perfect. And there is an animation. Yes, we can see two MRI. So the sound is not perfect, so do not hesitate to say if you have a problem to to hear me. I'm in charge of a neurometabolic disease center for adults, and in this field of the rare metabolic diseases, half of the patients are adults. So this is not a subspecialty, but this is an issue with big problems of means, of resources, and also of familiarization, of awareness among the adult doctors, because these rare diseases are less known than in pediatry. And for the leukodystrophies, we in around Paris we have more than 200 patients. So a few words of introduction about the leukodystrophies that Odile Bafsu-Tanguy has taught for several years. So the basis is this recognition by the MRI, and so we see the patients with their MRIs, and with the problems of the magnetic fields evolving, and so the classic definitions sometimes in this we lost some semiologic markers, and we have less T2 flares. So you can see a hyper signal T2, which is very diffuse, and in these leukodystrophies, we can see the D2 1, and this will lead us either to the demyelizating leukodystrophies, or the hypomyelating leukodystrophies. And in the leukodystrophies hypomyelinating, we have a slight signal of the gray substance, and this is a good marker. So there is no treatment at the moment for this, and in the adult it's just a small part of the leukodystrophies, but we have to think about that because this is important for the diagnosis. So there is this very light impairment in the dysfunction in the D2, the T2. So today we will talk more about the demyelinating leukodystrophies, and we have these points helping us for the semiology, where you have a symmetric distribution opposed to the acquired form when you have some lesions, and lesions can be asymmetric with some different age criteria, but this is not absolute. There is leukodystrophy that we have to mention because it's curable. But I will begin with the genetic leukodystrophy, demyelating ones. With a clinical case, this patient has from 40 some walking disorders with some falls, and it develops to a paraplastic, and with an impairment of the callus body, and there is a dosing of fat acids leading to a diagnostic of this disease. This patient had an MRI who was already an issue and alarming, and this patient has a quick cognitive decline, and he also had some environmental factors, and he has this very severe evolution. This is a frontal impairment, parieto-occidental, and he will deceased. He will died 6 months after of a cerebral form of adrenodystrophy, and this comes from a mutation of the gene ABCD. And a few words about this disease. This is the most frequent leukodystrophy in the child, the male child, and in the man. So adrenoleukodystrophy. And this adrenoleukodystrophy is linked to a mutation of a gene transporting fat acids, and the fat acids we eat them, but they are used for an energetic objectives, but also they are used, and in order for this fat acid to be used for energy, they have to enter the biolosigam, and we have a loss of major functions in the man. But in women, we cannot cannot see the fat acid. So it comes to it leads to a suprarenal impairment, and there is an inflammatory cerebral form, progressive form, and I'm talking about men because in children it's about 1/3 of the children who will have this impairment, but in the adult it is very underestimated. A lot of doctors don't know this form in adults. So with this impairment, which is more than 50%, which is frequent, and which can lead to a frontal impairment or cortino-spinal impairment of the auditive ways. And why it is important, and before 50 years we can use we can use a medulla transplant, but after 50 it can be very toxic. So this marrow transplant, and to insist on these histories, these pathways of men coming to the reference center, but in a high number of cases it's too late. So this man has a known disease and he has an MRI surveillance. He was 30 years old, and but this monitoring became less frequent. And on this slide, so he didn't have any MRI during 3 years, and 2018 he did an MRI, and an MRI in the context of a change in his career, and in 2020 his disease was very advanced, and there was a high cognitive decline, and this patient developed an impairment of the internal capsula. So it was difficult to see because this patient had a neuropathy. We can give some hyper signals at this place, and that's why we developed these RCPs. And so the contrasts taking is another marker of seriousness, and but it was too late to propose a treatment, and so this patient deceased quickly. So the transplant the last series, I present the last series about the forms in adult, because we know this transplant in the adult, but not, but in children, but not in adults. So why do we make a graft, a transplant? It's because the macrophages or a microglial cell, they will they are in two states, and ABCD1 intervenes in has a key role in this macrophages intervention towards a state, a condition which is a pro-inflammatory chronic status, and which will favor this. So the idea we want to make a transplant not to improve the neuronal component of this patient, but to replace the peripheral immunitarian system. So the efficiency is very good when it's done as at an early stage, but it's in once we do the transplants, we need several months, 6 to 9, to have a benefit. And there are all the risks linked to the transplant, which are important. So we work with some transplant centers, and hence the RCP that we have organized. But if it's at an early stage, we can have in some patients a recovery to the former condition. There are some conditions to do these grafts. So at more than 50 for the myeloablation, it's not possible. And there is also the prognosis. We have to take into account, hence the importance of other therapies in development. So on these molecules, a few words. This balance between inflammation and regeneration is driven by metabolic changes within macrophages, and it depends on the mitochondria and the glycolysis for this inflammatory state. And so it gave us the idea to work on the molecules which will activate PPAR gamma, and this is this product called hereditazone, which will inhibit the FKB, which is a known way for the inflammatory. So there is a pro-metabolic and anti-inflammatory effect, and in a phase 3 study led by the company Limerix, it was done to evaluate the benefits of this treatment in the myelopathy. And so the surprise is that it was followed over 2 years, but the patient had to have no cerebral form, and it was part of the secondary criteria. So in the placebo, there was a ratio of 2 patients treated for 1 patient under placebo, and the majority of the patients. So this is now using ATU for patients who have cerebral forms for which the transplant is not possible. And we've seen this was a very preliminary state, and in some patients, a complete stop of this inflammation. And for some patients, so there is a regression of these lesions in the context of hypersignal. So the genetic counseling is quite urgent. It doesn't mean that we should go to the families and do some fat acid assessments. We need to be accompanied by the genetic centers in order So this was a diagnosis that was made post-mortem, and we have seen that there was already some children deceased at the age of 10, uh, and we have to know that in the in women there is no cerebral forms, and one third develop a neuromyopathy, and one third have some signs but that are less disabling, and one third have no impairment linked to the disease. So we do surveillance. So as soon as we have detected a man with this impairment, so 69, a patient 69 at 69 is too late for graft or transplant, but it can have this molecule, and so we suggest this international recommendation for the follow-up for children, close follow-up, and then from 14 years an annual follow-up. So I will talk about other diseases. So this is a 15-year-old female patient. It began with a psychiatric impairment, so associated with an impairment of the white substance. So psychosis. It was a psychosis with visual hallucinations. So it should be red. A red flag, and it was a bilateral cataractus also, and this patient had this MRI, but she had this anomaly, that the xanthomatosis, the cerebrotendinous xanthomatosis, and xanthome, and we shouldn't wait to have this anomaly at the tendons to suggest the disease. And these keywords, atypic psychosis, and so for this, it's very important to dose the cholestanol, which is the biomarker, the most simple biomarker associated with this disease. So we are on the biliary acid synthesized from cholesterol with this hepatic enzyme, several oxysterol, which are altered, among which the cholestanol. And why do I show this way? So it's to show the interest of this treatment. At the moment, we have this chenodeoxycholic acid, which is one of the two biliary acid, exercising blocking of this, and a clinical improvement, that we give the chenodeoxycholic acid, because this is the one who will lower the disease and so attenuate the disease. So we had described the natural history of this patient, where there is this history of diarrhea, which is not reported in the interrogation, but between 7 and 15 years, that's where the patients develop cognitive impairments and cataracta. So we have 10 to 15 years to diagnose, before 25 years, when there are all these difficulties of walking and psychiatric difficulties. The xanthomatosis can have all these manifestations, including dementia and psychiatric diseases. And if we can treat before this point of 25 years, we can have a stabilization and a reversion of certain impairments. Some cerebellar ataxia have disappeared when it's treated before 25, and all the series that were made this recent year shows that it's very important to manage this before 25 years. And another natural history, depression and suicide ideas in a woman of less than 50 years. And these women ended in the emergencies and emergency unit of the hospital, and you can see encephalopathy and MRI showing a very high atrophy and an impairment of the white substance. And this patient has a deficit in MTHFR. This is another biomarker, and we had another psychiatric presentation with an impairment of the marrow, and this was a diagnosis of another group. This is another metabolic way. So we start from this biomarker, the homocysteine. Homocysteine has a fundamental role regulating part of the gene expression, hence the presentation in children in the retardation of the learning disorders, but to orient the diagnosis, because the homocysteine depends on the metabolism of the folates and the B2 vitamin, we help ourselves with some biomarkers. The synthetic malonyl in the urines, because if it's high, we will dose the methionine, because if this is high, we know that the blocking is the block is here, and hence the deficit in MTHFR. The treatment B9 and B12, but also beta-N for remodulation, and it enabled in this patient an improvement of the MRI, and she went out of the coma, and she recovered completely in the motor sense. To end these metabolic forms, I want to insist on why we dose certain metabolites in first intention when we see a myopathy which is not vascular. You can see the treatable diseases, cataracta, and there are some biomarkers, cholestanol, fat acids, and homocysteine. So the three, mentioned these three, but there are others. The MGE is not easy to diagnose, because this is a rare mitochondrial leukodystrophy, and there is this impairment which can affect the white matter. And if we do a muscle biopsy, there are very clear mitochondrial anomalies. The important message is the hepatic transplantation is so this transplantation works very well. Hepatic transplantation. There is an exception to this rule. There are several, but one that we shouldn't forget on these treatable, curable genetic forms. Because it's treatable, so this patient, which is a 30-year-old, after a small cranial trauma develops pyramidal impairment of the lower limb, and his mother has deceased at 38 years with a yes, was is deceased of sclerosis, of multiple sclerosis, and when we and you can see the occipital impairment. So this woman during his pregnancy developed this asymmetric affection impairment associated with a slight cognitive decline, and it will be treated like the multiple sclerosis. And 3 years after, she had a dementia. And this is the MRI, which is not very typical for metabolic leukodystrophy. But contrary to the multiple sclerosis, there can be there is no contrast making. So this is a leukodystrophy linked to the gene CSF 1R, and the life expectancy is 5 years, so it's very lethal. And about macrophage and microglia, this gene has a role in blocking these macrophages, and hence the idea to do a transplantation. So, and in this woman whose mother died at 38, and there is, when we follow up, the lesions have completely recovered, and this woman has stabilized the disease, and we've done other transplantation. And if it's done at an early stage, we can stop the evolution of this disease. So, in conclusion, for this disease, the biomarkers, which are very useful. For CSF1R, we don't have, but it's only on the panel of genes of leukodystrophies. And to do a quick diagnosis on the adrenal leukodystrophy, the biomarkers are essential, and there is the RCPs. So thank you very much for your attention. Thank you to all for this presentation. Are there any questions in the room? Good morning. By seeing the patients which were presented, some had some frontal lesions, but the syndromes, the depressive syndromes they have, is that apathy? Were they explored for an apathy from frontal origin? Well, exploring that, there wasn't any dedicated exploration, but there can be a link. So either these are frontal affection, impairment, or corticospinal impairments close to the thalamic impairments, with an likely involvement of all these emotional regulation aspects. But in all these symptoms, especially depressive symptoms, have been considered like coming from the life environment of the patient, so they weren't explored. But with Caroline Sebin in pediatry, we want to insist to the families of this patient, we shouldn't alert in every depressive element, but in this disease, it can be the first symptom, and we shouldn't hesitate to compare the MRI or to come back to the reference center because that's maybe the only time where we can intervene. Thank you very much for this very instructive presentation. What's your experience in your series of xanthomotor cerebrotendinous? We had a case beginning at 48 years, and concerning the treatment, you said that you wanted to initiate the treatment before the age of 25, but for the later curing. Our experience is, and the other series, American or Dutch, is not very good, but we have to ponderate weigh these according to the age and the duration of the evolution. It's about 20 years. But it depends on the severity. We had recently two patients where the diagnosis was made after 30 and 40 for another patient, and there was some cerebellar, but it was only a beginning impairment. But the evolution, we have less. The evolution seems to be stable so far. There is a factor of age, but also of overall severity of the disease. And one of the markers that we find useful, the impairment when it begins to be cavitary or in hypo T1, it's really the prognosis. We had a patient at 18 years who didn't have access to the treatment, but he already had a cavity aspect of the key teeth. Thank you very much, Fanny Odile. So we will now have Thank you. Thank you, and have a good work. Thank you very much. So we'll now have the next presentation about the canvas syndrome with Guilhem Solé, our coordinator at the center, and Professor Cyril Croiset, genetician in Bordeaux, an expert in neurogenetics.
Good morning, all of you. I want to introduce myself, and this presentation was actually drafted with my colleagues from Limoges. We did it together. Pointer, please. So, clinical case, 55-year-old patient. We saw him first consultation in 2014, and there was a first observation with paralysis at the upper limb. So sensitivity or missing some sensitivity of the upper limbs. Dysphonia. The past, he was not drinking, he was not smoking. When we just poor diagnosis, the beginning of pain, paresthesia, and for 6 months, not dysphonia, quick affection, the electromyograms. And so there's no motor, so motor-wise it could walk, neuropathia with those who with doing electromyograms, diminishing of the range of the cerebral nerves, and that have not disappeared, and the radius nerves that are at the same amplitude, the same range as the cerebellum. So neuropathy, that was indicating neuropathy. So affection of the cellular body, of the fibrosensitive, but not affecting the axon. So we wondered whether it was paraneoplastis, just BGSA, just regular, immunology, just regular as well, scanner, CAP, which has a left renal body lump, and TP, just regular, TDM, just regular as well. So possibly we thought that we have a neuropathy, paraneoplastic, even though it wasn't developing quickly. And so we give him a treatment and go to see the urologist, and ENR say, well, okay, well, not much, and the others say, okay, we need to operate. Carcinoma, grade 2. Carcinoma, grade 2. And granuloma, the hypothesis is that when he was intubated, the granula possibly just was ejected. So that's what they say. Surgery did not change anything. We gave him immunoglobulin treatment. We feel he's not moving, he's not doing better, and ENG is getting worse. Quite a few nerves have disappeared. And I did this ENG. He was coughing throughout the whole examination. Neurosensitive causes, inflammatory, whether pure inflammatory reasons, causes, toxic causes as well, solenoplatin, supplementation too high in vitamin B6 and B12 as well, mitochondrial disease. We don't have all diseases listed, and a deficiency in vitamin E. And across the last 10 to 15 years, we've come across this syndrome that was described with an affection, a cerebellar affection, or affecting the cerebellar ataxia, neuropathy, vestibular areflexia syndrome. Canvas. So initial papers which I read, I didn't get what they were trying to do. Is genetic studies and the first sets of series. The symptom that is most frequent, the white bars is at the beginning, and black is at the time of the inclusion, when we input this inclusion. So disbalanced, unbalanced. Unsteadiness, cough, sensory symptoms, oscillopathia, and various other symptoms as well, diarrhea, dysplasia. And this is the age range. The first symptom that appears is coughing. And when the genetic test results came back, we had a confirmation that was a canvas. So we treated him, as for other causes, while he had canvas. Ataxia symptoms, cerebralis. The point was to have a complex construction with a method of the paper methodology, several teams, groups working together. Expansions are cause of idiopathic sensory neuropathy. So this sets of 34% of neuropathies would be canvas, maybe not sensitive neuropathies, representing 34% of neuropathies. I don't really believe this. If we look at those criteria, 30% are ataxic, which is not what I see on a daily basis. In this paper, they say that it's long-lasting, abnormal lower limbs affecting the lower limbs, pinprick as well, abnormal pinprick, and it's predominant in the lower limbs. What is interesting to see here is that if you look at patients with movements of the upper and the lower limbs, a large proportion of these patients keep their reaction time, and they react. So the whole point of the neuropathy is that when you actually keep to your reaction time. And neuropathy is depends on the length. Well, it's long-lasting. 52% of the patients did not have nerves, neuronerves, or sural nerves. To me, it's a neuropathy which is not dependent on time. Filicum discerche, possibly they were classified as neuronopathy. And if you look at the ranges, the mean average on the radial is really low, 2.6. For those who know about it, experts, they know that 2.6 is very low. And the sural, we should reach 15. That was a long paper. Sural, medium. So atypical presentation, a patient. She's 34. She's got neuropathic pains, and she's had that's been developing since 30, with a vascular observation very negative, no, and that she's reacting. Here she is. Her feet are extremely red. She's erythromelalgia, quite severe one. And you find this clinical table and data. Left motor median nerves, affected nerves, and it's showing that both upper and lower limbs are being affected. And same as the previous person I told you about, she was coughing throughout the examination. So we could make a mistake in the diagnosis. First, a canvas, even if they are used to canvas, was only mentioned 3 times, and for the other patients, neuropathy, immune-mediated neuropathy. What is interesting here is that there was an abnormal of an epidermic infection. So you can't see values, but this is prevalence of coughs, depending on the papers, and this is across time. Now we ask patients. Cough was not part of we would not ask the patient whether they were coughing or not, but now we do. One last thing is that it's another entity, another parameter you need to look into. Some papers say that some of the motor function may be affected in extrapyramidal. You don't see the TEP scan, but dead scan, not TEP. With description of a Parkinson disease pseudoatrophia. One patient who had Parkinsonian syndrome with a double neuron and motor and sensitive neurons. In actual in practice, actually, when it comes down to it, when we have sensitive symptoms of the MIs, we need to do an ENMG, including the motor S, the MS. Sensitive symptoms, asymmetric one. The asymmetry does not mean that it's a neuropathy. So when you have a sensitive neuropathy, you got to wonder and ask the question, are you coughing? If they are reacting, maybe think of a canvas. And ataxia as well, look into the ataxia. And do MRI, encephalic MRI. So thank you, Guillaume. So your neurology is covered from a point of view of neuropathy. I would have said, in the ataxia. So this is the main form of cerebellous ataxia of someone who is 50 years old and older. So this is very important. So if you look at the genetics, it's a bestseller, molecular genetics. And in neurogenetics, that is mutational that really concerns us since the 1990s. First stage, the golden age. That was, we had the 1991 discovering Steiner disease. Huntington disease as well, that played a crucial role in definition of genetics. And Sanger as well, with methods which were used to find the expansion stage. In the years 2000, with we moved on to new sequencing. So we read it in different ways, and when there are repetition of the nucleotides that repeat over hundreds of thousands of bases, a nucleotidic, these tools are not performant. Are not doing the job. So there is a gap. All the techniques that we had available at the time did not make it possible to find out more about. So a third generation of sequencing, slicing technology makes it possible to read these baselines on DNA, 100,000 bases. So laboratories were reading up to 1 million baselines, one after the other. So second golden age of this mutational stage. ALS, gene 72, main gene 72. And then from C9 laboratories have worked with, with these new perspectives. And since 2019, there's roughly 15 new diseases that have been discovered, so including Canvas 1. And you can find this in the coding, so how do you find out new disease in the intron coding areas, in the intronic regions, that you don't find this protein sequencing that we have found recently, a syndrome canvas included. Repetition, various different repetitions. Canvas halfway in 2019, and then all these new ones in epilepsia, myoclonic epilepsia. In this slide is recessive, so there is no there is no family background or history. Late forms, cough even 10, 15 years before the neurology affection. Cerebellus form as well. The size, pathology size of repetitions can go up to 2,000. They are not triplets, they are 5 times. So we have several kinds of quintuplets. And the reports, that you showed, well, that we could see. First paper, Cortez's paper, that was conducted that was done in London. They used a whole genome sequencing to large size families that were likely to have a canvas. And even in Hungary, they ended up in gaps in the sequencing. They found gaps. 2,000 repeats, a lot of repeats and gaps. And these gaps, sequencing gaps, you've found with in same families or patients in the same family or and other families as well. And this ended in defining the fine-tuning of this sequencing, the in-depth sequencing, introning, and repeats that are different in structure with the different AL. This is the early stages of discoveries, and definitely the new ALs, new ones, just regular ones, and some that are allele, some that are not regular. So this is a technique that we've been using, this long-range PCR. We've been using this technique for the 1990s, and D-line is a positive canvas. So the PCR, long-range PCR is not working, it's not functioning. Therefore, it's a negative test, meaning that it's positive. Do you understand what I mean? Yeah. So as a diagnosis, it could be a manipulation issue during this process. So yeah, poor manipulation or anything else. The second technology that was implemented, or repeat primed PCR. So I have the regular allele, just a sound allele, and then a smear, and then I have this smear to show the heterogeneity of this pathologic allele. And this is actually done in Limoges and not anywhere in France, and can only work with triggers with HAAG. Can only be positive if the triggers you're using are already known. If they are pathologic, this cannot be positive, so be careful. You must be careful. You can have a canvas syndrome for which you have a negative feedback or test results, but still it is a canvas because the actual techniques we are using can fail. Take-home message, transmission, AR transmission. Molecular diagnosis still is complex in some situations, and be careful of the fake negatives. It's important to have NGS long read in this context, and to look for that would work as a diagnosis. You don't need to have a fine-tuned molecular specificity characteristic. Cerebellus ataxia. Well, it is a cerebellus ataxia, and for instance, to have access to coverage. So it's a new sequencing new sequency called the NGS long read. It helps with a fine tuning of the reading. And as I said, to some of you, it's the latest. So we were really bad only a few years ago. We're very bad in the showing the late of cerebellus ataxia that starts at 50 years old. So Canvas can explain up to between 20 to 50% of this ataxia. But there's a second gene that we've just found out about. So first paper has not been published yet, and not part of the French researcher that is part of it. It's SCA 27, SCAVEN 7, and conventional motivation FG94. In one of the intron of this gene, you can have amplification of the repeats, so repeat amplification, so late attack, cerebellus ataxia, with aggravating phases that could mean that it's a late onset. No, we have a third presentation. Huntington. That's it for me. Yes. Take over the Huntington. Yeah.
Thank you very much for these two presentations, very didactic presentations. Are there any questions? Does he cough FCF14? This is a late clinical picture. The mic, please, the mic. So, a comment. It seems very frequent, and I have several examples of patients which were followed for sensitive sensory neuropathies, and we have found the anomaly on the FCR1. So 34% doesn't seem a lot, but if we restrict these to 30% of the idiopathic, well, it could. A question: these patients have probably a vegetative impairment. In your practice, do you explore the vegetative fibers? Yes, they have a vegetative impairment, and the Limoges study shows this small fiber impairment associated to the bigger sensory fibers. There are a few patients for when the vegetative syndrome is major, but this is a minority of patients. This is not like in amyloid, but in my experience, only a few patients had this problem. Another element, the clinical spectrum of Canvas will enlarge with the central impairment, and as the example that you gave, we will see all the patients who have some multiple pains. Yes. I have a question. We've talked about Limoges as a reference laboratory for the genetic tests. Do they use third-generation sequencing? In diagnosis, nobody does it because there is no accreditation of these automates, of these machines for the diagnosis. So it's just some equipment in big platforms, or in genomic laboratories, but it's not accessible for the moment. We have a project, a research project with the CERCA to develop diagnostic tools by using a third generation machine. So I suggest we should continue with the last communication of the session concerning the Huntington's disease cohort of Martinique by Rémi Bélance and Ignacio Antolin Sanfelis. So the Martinican cohort of the Huntington disease. So for those who don't know, maybe the neurologists know are aware, but in this public, this audience, maybe people don't know. It's this is in inherited neurogenetic disease with autosomic dominant transmission caused by the mutation of the Huntington gene, HTT, an expansion of a repetition of the CAG triplets on chromosome 4p. This expansion amplifies over generation. This is a phenomenon of anticipation, so this means the disease comes earlier in life with more serious forms. This is a midlife disease. 60% of the patients are affected between 35 and 50 years. And it's a generation of mainly on the basal ganglia and specifically on the caudated nucleus. This is a very polymorph disease, and so this is difficult to diagnose in some cases. This can be very disturbing. So the prevalence is 5 for 100,000 in Europe. It's lower in the Asian countries, in China and Japan, 0.1 to 0.5 per 100,000 inhabitants. And in Africa, it's very rare, 0.1 per million in Africa. But there could be a bias of recruitment because of the lack of disponibility of genetic analysis and medical covering. The symptoms, the motor disorders are the most alarming. Choreic movements, Parkinson-like symptoms, dystonia, ataxia. The cognitive disorders are also present and can evolve in late disease to the dementia. Psychiatric disorders often lead to a problem of diagnosis with personality disorders, depression, and situation with suicide. There are a lot of patients who are lost to the psychiatric hospitals. So to illustrate the presence of these classical forms of Huntington disease in Martinique, in the CERCA experience, we had 22 patients distributed in 15 families. So this is so in Martinique, the frequency is is closer to the European frequencies than to the African ones. In 2001, I received, in consultation, a patient brought by his family. It's a 51-year-old man presenting behavioral disorders leading to difficulties in his work. He had several collisions with his delivery truck, and he had to change, to be changed in of work position. He had some segmentary choric movements and of the trunk with low amplitude, involuntary movement of the buccofacial sphere and ataxia. And also he had an apathy, and this was a typical, and it seems indifferent to his disorders. It was a typical presentation, but we made a test, a negative test for HTT mutation of the HTT gene. But it's only 2 years after that I received a call from Professor Dürr with a positive result of the mutation GPH3, so leading to a diagnosis of Huntington-like type 2 disease syndrome. The Huntington-like symptoms, general view, HDL1 was described in a Swedish family with an expansion of a repetition of octapeptide, and HDL3 is a recessive form in a family of Saudi Arabia, and there are some overlapping syndromes with HDL4 sharing its mutation in cerebellar ataxia, and neuroacanthocytosis and choreacanthocytosis in one case in Guadeloupe, with the neurogeneration associated to the pantothenate kinase and the syndrome of McLeod. So to come back to the HDL2, it was described first in 2001 in two publications, one of Holmes and one by Margolis. And this publication concerned a big Afro-American family of the southeast of USA, and they presented an expansion of CAG-CTG of the gene of junctophyllin 3, and this is a protein establishing a link between the endoplasmic reticulum and cytoplasmic membrane. And the penetrant, there was a complete penetrance from 4 repeats. The normal allele normally has 6 to 26 repetition, and from 27 to 39, the effect is variable. The maximum expansion was 59 triplets, but we have a patient in our cohort who has 58 with a severe form in the Martinican cohort. 3 pathogenic mechanisms were identified: loss and gain of function or toxicity by polyglutamates. This pathology is very rare, 69 cases in the world in 2017, and at the moment it's about 100 now. So this is the genealogy of the first family described with our patient here. One of his sons recently was affected, was diagnosed with a clinical impairment and the mutation well identified. Another son came in pre-symptomatic diagnosis, had the mutation and didn't express the pathology. And we had the surprise to see, to discover another family, a second family, a more numerous family, and this is the biggest family in the world, with patients identified on 3 generations. I will leave the word to Ignacio, my colleague Ignacio, about the figures. Good morning. Before talking about this family of HDL2 pedigree, I'd like to talk about the origin of these mutations and the incidence in the world. And the specificity of this disease is that they only affect population with an African origin. We don't have any cases in Caucasian people. What we have seen, they have detected funding effects in funding effect in sub-Saharan Saharan Africa, and then linked to a history of slavery. There was migrations. And countries which have reported cases, the US, Mexico, Brazil, Venezuela, South Africa, were now the highest number of cases, and then Botswana, Angola, Morocco, and UK and Martinique. So in our cohort, we have only one patient. We have 18 patients with HDL2 and 22 of HD. It's very specific. And why do we see this? It's because 15 families and the 22 patients of H2 are distributed in 15 families. It means that the families remain unexplored, but the 18 cases of HDL2 are distributed in 2 family only. So we've seen all the HDL2 patients on the island. So a few data about our cohort. The sex ratio for HD are similar, but HDL2, there is a majority of men. We don't have any explanation. It could be a mere coincidence. The repetitions, the repeats, it's 40 to 61 for HD and 42 to 58 repeats in HDL2. And this is a disease affecting the population of African origin. So in HDL2, we only have some Afro-Caribbean patients and no Caucasian, unlike HD. So 15 families for HD and 2 families for HDL2. And this study is important because this is the first study in which we have a family with 3 generations which were tested. This is important with screen. It's important because it will enable us to see if there is an expansion, some anticipation. The 3rd generation was formed for only 1 patient. So this is not a very reliable result, but we can see in the 1st generation was composed of 7 patients and 45 repetition, and the 2nd generation is composed of 7 patients, 45.5 and 42 in the 3rd one, but it's not reliable. But what we can see in the father transmission, there is on average an increase of 1.6 triplets from one to the other generation. It is not the case in the mother generation where we can see this. So that's the same thing that we can see in the normal Huntington disease. Generally, we haven't found any differences in the 2 diseases, but it could be linked to the low size of our cohort. So 18 patients is not a lot. We've seen some results who are close to the level of signification. The onset of symptoms and diagnosis age are 5 years later in HDL2 compared to HD. And the symptomatology, chorea is the dominant symptom, and dystonia was more common in the HD and Parkinsonism in HDL2. So we can see here the distribution of the number of repeats compared to the onset of the disease. In the HTT, we have detected a significant negative correlation between the onset of symptoms and the number of repeats. It's well established in the literature, but we weren't able to see this with patients with the JPH3 mutation. And why? This is because of the low variability of the number of repetitions. We can see that the red points are very grouped, and it's linked to the fact that we have one extreme case. This case is with 58 repeats, and which began the disease at 6 and at the age of 6. And in the literature, that's the case. It's a younger case in literature. But in fact, this extreme case is a clear example of how, of the anticipation and expansion of this disease, because his father had 54 and he went to 58 repeats in one generation. So I will leave you with Dr. Belance, who will give you some conclusions. So everything leads to some implication. This is a specific involvement. So the diagnosis have to be adapted in our region, because we have both pathologies at the same level. So in the research, we have to request the two mutations in the research, HTT and GPH3 in our population. Also, you've seen that this pathology is very rare around the world, and our own research cannot lead to conclusions about the characterization of this disease. So it's important to share the knowledge and to pool the knowledge and develop an initiated activity under the form of a consortium by INASIO and with all the teams of the different territories concerned with this pathology. And especially we have to develop some activities with the Caribbean countries, especially Trinidad, where there is probably several families existing because some choreas are known and they are negative for the HTT mutation, but there wasn't any research for GBH3 in this country. And also in St. Lucia, there is a known case of non-characterized chorea, a patient detected in the US also. So we have a lot of work to do in the region on this point. And we also have to do some research to improve the knowledge of the physiopathologic mechanism of HDL2, and maybe work to initiate the work on the therapeutic therapeutic ways and solutions. So I would like to thank Professor Cyril Loisette for his important contribution and input since the beginning to analyze the patients of Huntington disease and for the development of UHTRS, and to Sophie Duclos and all the team working on this, and the MPR for their involvement, and psychiatrics, and also Gregory, a neuropsychologist, who made a psychoneurology analysis. And so this is a good solution for these studies. Thank you very much. Thank you to both of you for this presentation with a very large family. There were 4 generations, I think, in this family. No, the first generation wasn't explored genetically. We haven't had any tests. Are there any questions? No questions. So it means that this presentation was very clear and complete. So thank you. The break, so what time should we come back after the coffee break? So maximum 15, okay, 15 minutes of pause. So at 41, we come back.
Bonjour, on va démarrer si on ne veut pas trop tarder pour...
Okay, we're going to start. Otherwise, we're going to be late for lunch. So, session on cardiopathy, and we're going to start. Aïssatou Signaté. She will present on neuropathies, familial amyloid neuropathies in the West Indies. That's from Dr. Aïssatou Signaté. Good morning. I will present on, I'll tell you about what's going on in the Antilles and the West Indies, more specifically in Martinique. So before I tell you about the familial amyloid neuropathies, sorry, yes, some time to adjust. Give me a minute to settle, and then. So globally, through time and in the world, amyloids, what are they? Cardiomyopathies, more than neuropathies. Today, after the first three hubs or centers in Portugal, Japan, Sweden, there are 135 spots in blue, mutation, isoleucine mutation 122. So it's a cardiac mutation that's widely extended, spread. And there's a first described in the first three spots where it was identified. So distribution across the world is not homogeneous, and starts in Africa, sub-Saharan Africa, and actually is affecting quite a few parts of Africa. So we find them in the Caucasian population, in Brazil, large community from Portugal. So quickly, for those who don't know much about it, it's a familial amyloid neuropathy. The gene is the one coding for the transthyretin. Transthyretin, what is transthyretin? It's a protein that is used as a carrier of vitamin 1. It's a tetramer produced 95% by the liver. And this tetramer it falls apart, and there are some aggregates, and the tissue is, and especially in nervous autonomous system and the heart acts on these organs, and there's a local production of transthyretin of the plexus around the plexus area. So over 100 mutation with a phenotype which is really mixed cardio and neuropathic. Patients are mixed, and especially when older and becoming a bit more cardiac with cardiac diseases. and neuropathic and cardiopathic. Myelоsis, Portuguese myelоsis is at this end of the spectrum. So we've got a cardiac form, which is very present. Neuropathic form that we've known now since the year 2020. And there's one patient, which is form 68, which is a cardiac form. It's a mutation which you see, which we've come across in Italy. So clinically, typical form is a Portuguese form. So form 30, it's a small fiber, so affecting the small fibers, somatic. It's a neuropathic affection, which is neurodependent, and dystonia, which makes it difficult to move, diarrhea, which socially is difficult to handle. In some forms, when you see that there is no there is an endemic, and it's a late development and sporadic as well. So sometimes you don't see any background. There is no historical background. It's a neuropathy which, from the start, quickly is going to affect all fibers. There's no dystonia, but often, well, actually, we do see dystonias. Amylosis as well, we need to be careful and wary of it. And specifically neuropathy, dystonia, we've just mentioned it. And that should rule out any inflammatory causes and loss of. That's from a clinical point of view. Often patients are treated and treated for other reasons and for other causes, but actually is a red flag. We need to flag this gene, transthyretin gene, a mutation, which is a mutation that has been described since 1994 and with Caucasians. So cardiomyopathy, it's a mixed form with a carpian channel affecting vocal cords, nerves, dysphonia, and a hard time patients find it difficult to swallow. That's been described since 1990. Another mutation, VAL122, which is an isolated cardiac form, often a carpian channel. Amyloidosis, cardiac amyloidosis. So this curve, you all know about. We have them in Martinique as well. We VAL120. We identified VAL122 mutation, and for 8 years we thought it was only. But in 2008, we have came across another mutation. First, isoleucine 122. We thought it was VAL107 actually, and no, it was isoleucine 122. And it just went up the roof. We do not have precise figures, but we are around 200 patients with this type of cardiopathy, and 50 patients for VAL107 mutation. In neurology, the neurology unit. When do we actually talk about this amyloidosis, transthyretin amyloidosis in neurology? Is when we come across a mutation, VAL107. Last typical situations when we had the first case, the first patient we identified, there were patients that with a Scorpion channel, and they had myopathy. So we have patients with with a diagnosis, embolic diagnosis, FA, cardiopathic alloid, and sometimes an etiologic diagnosis. We come across amyloidosis. And this is a new diagnosis, sometimes with a previous diagnosis. And briefly, the clinical picture we draft of in the paraclinical for suspicion of an AF to TTR. The diagnosis. Regarding the diagnosis, we now are a bit more acquainted with this kind of diagnosis, so we're going to do scintigraphy as soon as there is a suspicion, and quickly we turn to molecular biology, depending on the background. And there is a lot of family background here, or family ground for this here in Martinique. So this is to show even in neurology we have to do these scintigraphies. And even some colleagues send us these patients, and this pattern, magnetic pattern. Then they had to have this scintigraphy. Quickly, we went and looked at those 45 patients with VAL107. So the whole set of 45 patients, all with VAL107. Most age range is 60 to 69 years old. 21 families with 14 women and 34 women and 21 men. So family-wise, they 22%. We have patients who is going to end up his life, bedridden with diarrhea, and 44%, with grandparents, were bedridden, and 44% who had just regular family backgrounds. 2 patients had the cardio symptoms, and another one evolved in a small neuropathy. And out of the 45 patients, 43 who had NAF. Development of this illness or disease is 7 years old. The cardiopathy, their life expectancy is short anyway, 5, 7, and 6 years old. 6 years, not years. I'm going to cover this quickly. Neurologists now know this, are well acquainted with it. The affection of all fibers. Hands first affected, at the same time as the lower limbs. So that multifocal disease. So we often think of an inflammation, amyotrophy. That's quite showed, with the hands that you can see on the hands and the arms, and inflammatory. So red flags, loss of weight and early on. Scorpion channel, 50%. Cardiomyopathies is not always symptomatic. Some problems with swallowing. These patients the patients were older. One patient here, dystonia, not really severe, but we we actually noticed that these patients often have issues with dysautonomian issues. Diagnosis that takes time to reach. Out of this set, 44 patients, because one patient, we had a quick diagnosis. Out of the 44 patients, we have 13 and 10. So we got 2 patients that really corresponds to that is actually PNDS. So with severe handicap, disability. So some issues with diagnosis as well, and with the rest of the West Indies, we don't have enough information. From Saint Lucia, we've got another patient with Valin 30. A patient that was treated for PIDC, but a wrong diagnosis in Guadeloupe. A mutation either 122 is well distributed, and VAL 107. That was a patient from a mixed family. The VAL 107 was transmitted by the Martinique-based family relatives, and so we thought that it was a VAL 107, and for French Guiana, there is more discrepancies between the results. It's a population that also French Guiana, and French Guiana, it's a small. No, it's not small at all, but it looks small. No, it looks small, but it's actually massive. It's on Guadeloupe, French Guiana. There is a Methylene 30. We got VAL 107 from Martinique, because these patients usually are from Martinique. In the 1990s, we had patients from French Guiana that were VAL 107. And finally, there you go. This small snippets. 60-year-old patient. She goes to vascular neurology. It goes well during the hospital. She said she lost a lot of weight, and okay, we're going to do a scan outside, and she was doing well. Actually, she went out to the hospital, she left, and I saw her 2-3 years later. And stroke. Yeah, she had sensitive disorders, and actually it was VAL 107. So this patient who had this, you see loss in muscles and tissue, muscles, cardiopathy, VAL 107. She had a stroke, and then we had her, and she had. Thank you for listening. Thank you for this this excellent presentation. Thank you so much. So 15 patients, right? Questions? Do you have any questions? Quickly. I believe I've got a patient from Cambodian origin, and she's got a myeliosis, and I think he might be of the same from the. Yeah, you're from of Cambodian origin. Yes, the father, I think, transmission was via the dad was transmitted this disease and passed away. Yes, I had a question. Carpian channel. It's typical, yes. Often, and yes, often they have a specificity. Often they had been operated on, but it wasn't just that. They had a neuropathy development, which was not a good development, and therefore that's why we we did a biopsies, and so we ask laminosis. We find laminosis even though there is no homeopathy, signs of homeopathy. So we do the biopsies now. As, I think we were going to move on to the next speaker. Thank you. Very interesting. Thank you very much. So, Professor Lamonos Ishanis Laguna, amyloid and neuropathies updates on the treatment.
So, good morning, everyone. Thank you for inviting me. So, thank you, everybody, for this invitation. It's always